Webinar and starting Facebook feed in 1 second. And we are live on Facebook and we are open for participants to join us. So I want to welcome everybody. We're going to give people a few moments to populate and we will be beginning the presentation shortly. Ugh. And there's the one place I did not change a title. In fact, I have the wrong presentation up, but they know they're in the right place because, you know, this is what happens when you multitask. So we're going to do a stop share here for a second and welcome everybody who's joining. We have a number of you already joining in the room. And Lisa is being just ridiculous because this is, okay. So we're good to go there. All right. So we're going to go back over here and we're going to start in just 1 second. Share screen. Now I'm going to share my screen. This is what happens when you do a whole bunch of these tour events and you have all of your slide decks piled on top of each other. Good afternoon, good evening, wherever you're watching us from live. It is December 3rd, 2020. Yes, you heard me right. It's still 2020, but we made it to December. So everybody just take a deep breath. We only got a month to go or so. So we're almost out of, well, 2020 anyway. So while everybody's populating both on Facebook stream and coming into the attendance on our Zoom meeting, a couple of housekeeping notes. We are streaming live on Facebook, but the meeting is taking place in a private Zoom webinar. The link to join the webinar is in the Facebook feed. You may join the webinar at any time. We will not be addressing questions from the Facebook platform. We are merely streaming so you can watch it in real time through Facebook if you didn't get the login or you forgot to sign up. So you can watch us there, but you have to join the webinar to ask questions. For the Q&A portions, there is a Q&A feature at the bottom of your Zoom control panel, and anybody who's in the Zoom room can ask a question at any time through the entire presentation. We will take question breaks at the end of each talk and at the conclusion of the meeting. So we may address your question in writing or we may wait and address it verbally. So if you want to ask a question at any time, of course, pop it in there and we'll address it. If we, let's see, what else do I have to tell you all? Normally this is it from in a meeting and I'm standing in front of you. I'm telling you where the bathrooms are and everything else, but I think you know where they are wherever you are. So we don't have to do those housekeeping details today. You're going to get a poll in a few minutes and I'm going to ask you to populate that poll. And that lets us know where you're watching us from and a little bit about your HCM experience. So we make sure that we're speaking to everybody, whether you're evaluating your treatment options for a device or surgery, or you're newly diagnosed or multiple family members are diagnosed. Give us a feel for who you are in the space of HCM. So I will put that poll up in just a moment and you can take that poll until I'm done speaking later. I am going to hand off introductions. So then we come back into the Brady Bunch look. I am Debbie Hamilton is joining us with her brand new less than a week old heart. Yay, Debbie. So congratulations. So that's fantastic. And she wanted to say hi and let us know she was here. So I think that's really, really great. And my goodness, you are knocking it out of the park, girl. Congratulations for being up and about and wanting to watch us. So I'm going to hand it off to, oh goodness, I just lost my agenda. It's behind me. Ashley and Stacy are going to tell us a little bit about the night's events. So if you guys want to do a share screen, whoever has the screen, and then you can unmute yourself and say hi.
Hi, my name is Ashley Fitzgerald, and I am one of the nurse coordinators for the HCM clinic at Intermountain Medical Center. I am just one of a team. My other half is Stacy Brooks. Say hi, Stacy.
Hi, like Ashley said, my name is Stacy and her and I are the HCM nurses. I'm sure a lot of you already know us that are patients, but we look forward to hearing from those of you who aren't.
Yeah, we mostly talk to you guys on the phone, so this is a chance for you to get to see us and know us a little bit. Let's see. Can you guys see my screen?
Not yet. Not yet. So do this share screen at the bottom.
I'm new to Zoom, so.
For any more of you out there new to Zoom, it's so cute.
It's working now, Ash.
There you go. Now, yeah, then you can put yourself on present mode. And there you go.
Okay, so this is Intermountain Medical Center. That's where we're housed in Murry, Utah. This is our team of physicians. So our two clinical physicians are Dr. Kia Afshar and Virginia Hebel, both of which you'll hear from tonight. Dr. Min is one of our imaging specialists. Then we have Dr. Jared Miller. He's one of our heart rhythm specialists. Dr. James Orford, he's one of our interventional cardiologists who specializes in alcohol septal ablations. And Dr. Bruce Reed, who is our surgeon who specializes in septal myectomy. Our program started, I think, at the tail end of 2015. And in 2017, we were designated a Center of Excellence by the HCMA. And this is a map of the Centers of Excellence. There might be some more now. I'm not sure if this map is current. But I just wanted to welcome you and thanks for joining us. And I wanted to introduce Dr. Virginia Hebel, who's going to speak first tonight. This is how you can get a hold of us. Our phone number is 801-507-8HCM. And we also have a website. You just go to intermountainhealthcare.org and you can search for HCM. On our website, we have some general information about HCM. You can request an appointment and then how to get a hold of us. Thanks.
Thank you, Ashley, and thank you to everyone for attending Intermountain Medical Center's segment of this national effort by the HCMA. We are honored to participate. I am Virginia Hebel. I'm co-director of Intermountain Medical Center's HCM Center of Excellence. And I am looking forward to sharing with you an overview of hypertrophic cardiomyopathy. My presentation is based on the brand new 2020 American Heart Association and American College of Cardiology guidelines for the diagnosis and treatment of patients with HCM. Let me try to share my screen. The information I'm presenting may be very familiar to you, particularly if you and your family have been living with HCM. A very important thing to be aware of is that you are not alone. HCM is common, with studies from all over the world showing how common it is. It's estimated that about 1 in 500 people have HCM, and more recent studies show the prevalence may be even higher than that. What is hypertrophic cardiomyopathy? HCM is a type of heart disease that causes the heart muscle to become abnormally thick. The disease can develop any time in life, as early as before birth or not until advanced ages. Many people with HCM have been told they have a murmur their whole life. The disease can cause symptoms that can range from extremely mild to severe, including palpitations, chest pain, lightheadedness, and shortness of breath. The good news is that most affected individuals can achieve a normal life expectancy, and many do not experience disability or the need for major medical interventions. However, HCM can cause serious problems, such as abnormal heart rhythms, fainting, stroke, heart failure, or even sudden death. Thankfully, the mortality from HCM, even when complications occur, is very low with appropriate care. There is no cure for HCM, but there are medications, procedures, and lifestyle changes that can help affected individuals feel better and live a long and active life. Causes of HCM. HCM is a genetic disease that is shared by relatives of the same family. We have a segment later this evening that will take you deeper into the topic of the genetics of HCM and the importance of family screening. The result of carrying an HCM-causing genetic variant is that within the heart muscle, cells become disorganized and scar tissue can form within the muscle as pictured here. How does HCM affect your heart? The answer is lots of ways, and we'll go through each one by one. The hallmark finding in HCM is the thickened heart muscle. This increases the stiffness of the heart, making it more difficult for the heart to relax and fill with blood. So higher pressures build up in the top heart chambers in order to push blood into the pumping chambers of the heart. The thicker muscle leads to crowding of the pumping chambers, so there is less blood to be pumped to the body. In some cases, this leads to overt heart failure, where higher pressure and inadequate blood flow to the body lead to shortness of breath and inability to tolerate exertion. The thickening of the heart muscle in certain locations can lead to obstruction of blood flow to the body, called left ventricular outflow tract obstruction. In a sense, the heart caves in on itself as it is squeezing and blocks blood from exiting to the body. This occurs in about 75% of cases, with obstruction developing or made worse under certain conditions, like when a person is dehydrated, when blood vessels dilate, like in the heat, or when the heart is beating stronger, like during exercise. This obstruction is in part due to mitral valve problems. The valve often has elongated leaflets, with abnormal thickening and location of the papillary muscles that control the mitral valve. As the heart is squeezing, it caves in on itself in such a way that the blood cannot exit to the body as well, but instead is directed back toward the lungs through a leaking mitral valve. This causes shortness of breath, and in severe cases, edema or fluid in the lungs. A common symptom from HCM is chest pain. Chest pain can be due to the stiff heart, higher pressures, obstruction, and backward flow through that mitral valve like we reviewed. But on top of that, the blood flow through the small vessels within the muscle is often abnormal, called microvascular disease, and this can cause chest pain as well. Atrial fibrillation is a heart rhythm problem that is experienced by many people with HCM. Atrial fibrillation is an arrhythmia that causes the top chambers of the heart to beat irregularly and chaotically, which impairs the ability of the top chambers to deliver blood to the bottom chambers, and can also drive the bottom chambers to beat faster. For both of these reasons, atrial fibrillation can cause symptoms in HCM, including shortness of breath, palpitations, lightheadedness, and fatigue. The development of atrial fibrillation is an indicator of stroke risk. Since we know the risk of stroke is also higher in people with HCM, the recommendation is to start an anticoagulant or blood thinner when atrial fibrillation develops in order to prevent strokes. Ventricular tachycardia and ventricular fibrillation are dangerous heart rhythm problems originating from the bottom chambers that can occur in individuals with HCM. These rhythms can be thought of as short circuits that stop the heart from beating effectively. The short circuits typically develop around islands of scar within the heart muscle. When not treated emergently, some of these short circuits can result in sudden cardiac death. Most people with HCM are at low risk for sudden cardiac death. However, it's important to identify the small number of individuals who are at increased risk, so preventive measures can be taken, including placement of an implantable cardioverter defibrillator, or ICD. How is hypertrophic cardiomyopathy diagnosed? Your healthcare providers will take a detailed medical and family history and do a comprehensive cardiovascular physical exam. They will also order tests which are commonly used to help diagnose and monitor HCM. An echocardiogram is a non-invasive test that provides ultrasound images of the heart. Sometimes this test is done during exercise to see how the heart responds during activity. This test can be used to measure the thickness of the heart muscle, the size and function of the heart chambers, the pressures in the heart and lungs, and to determine whether or not there is obstruction. Cardiac MRI is a non-invasive test that uses strong magnetic fields to help make very detailed images of the heart structures and function. It is particularly useful for characterizing the heart muscle, including identifying larger areas of scar within the muscle. Not pictured here is the electrocardiogram, a brief non-invasive test that uses electrodes attached to the chest, arms, and legs to get a snapshot of the heart's rhythm and electrical system. There's also the wearable version of the electrocardiogram, a Holter monitor or ambulatory telemetry monitor. These record the heart rhythm over a period of time. How is HCM treated? There are a variety of lifestyle changes, medications, and treatment procedures that can help patients with HCM manage their symptoms and live a healthy, active life. Your treatment plan will depend on your symptoms, your heart's function and structure, whether you have heart rhythm problems or are at risk for dangerous heart rhythms, and also your other associated health concerns. For most patients with HCM, mild to moderate intensity recreational activities are beneficial to improve cardiovascular fitness, quality of life, and overall health. Your provider can give you additional information regarding activities that are safe for you. Sometimes baseline exercise testing or a period of supervised exercise is recommended. It is also important to be aware that for some patients, there are certain activities that can trigger worsening symptoms, such as eating large meals, becoming dehydrated, extreme heat and humidity, and lifting heavy things. Patients with HCM commonly take medications called beta blockers and calcium channel blockers. These medications relieve symptoms by encouraging the heart to work less hard, and this relieves obstruction, decreases the demand of the heart for oxygen, and helps the pumping chambers fill with blood. Patients occasionally take another medication called disopyramide, which can help decrease the obstruction of blood flow, but does require more careful monitoring. And Dr. Afshar will talk to you in a later segment about new medications under investigation for the treatment of HCM. Patients with obstructive HCM may be told to avoid some medications because they promote outflow tract obstruction and symptoms. These include nitrates like nitroglycerin, ACE inhibitors like lisinopril and enalapril, and certain calcium channel blockers like amlodipine. And diuretics can also make obstruction worse. Arrhythmias are a common problem for individuals with HCM. They are best managed by heart rhythm specialists with expertise in HCM. Beta blockers, calcium channel blockers, and other anti-arrhythmic drugs can help with arrhythmia management. And when medications are not enough, there are procedures like cardioversions and catheter ablations that may be helpful. Anticoagulants or blood thinners to prevent stroke are often indicated. Also, as mentioned earlier, some individuals are found to have risk markers for sudden cardiac death and may benefit from placement of an implantable cardioverter defibrillator, or ICD. Extended septal myectomy is a surgical procedure that permanently removes some of the thickened heart muscle to allow for better blood flow out of the heart in cases of left ventricular outflow tract obstruction. This is an open heart surgery done by a cardiothoracic surgeon under general anesthesia. This procedure is typically beneficial for patients who continue to have severe symptoms despite taking the optimal medications for HCM. Alcohol septal ablation is a procedure done in the cath lab by an interventional cardiologist to reduce the thickness of the muscle in the area of left ventricular outflow tract obstruction. This procedure is for individuals who are unable to undergo surgical myectomy. A small amount of pure alcohol is injected into the thickened heart muscle through a heart artery. The alcohol kills the muscle cells, and over time, the muscle will shrink to allow blood to more readily exit the heart. Individuals with HCM are often affected by other health conditions like high blood pressure, high cholesterol, diabetes, obesity, sleep disordered breathing, and even other heart problems like heart attacks from atherosclerosis or hardening of the arteries. It is very important that these other conditions are well cared for, and whenever possible, early preventive measures are taken to avoid these additional stresses on the heart. Another special circumstance is pregnancy. In most women with HCM, pregnancy is well tolerated, but is best approached with a multidisciplinary care team that includes cardiology, genetics, and maternal fetal medicine. Finally, in rare cases of HCM, a person may experience weakening of the heart muscle called systolic dysfunction. When this occurs, it is often appropriate to involve a heart failure care team. The treatment strategies are adjusted to the heart's changing needs, and in rare cases, a heart transplant becomes necessary. At Intermountain Medical Center's HCM Center of Excellence, we provide the entire spectrum of HCM care, including primary and comprehensive HCM care. Primary HCM care includes patient education, clinical diagnostic assessment and testing, genetic counseling and testing, symptom management, blood pressure management in cases of obstruction, sudden death risk assessment, stroke risk assessment, and coronary artery disease risk assessment. In addition to these primary services, we provide the breadth of comprehensive HCM care, including determining HCM versus HCM mimickers, screening at-risk family members, cardiac care when just the genetic test is abnormal, alcohol septal ablation, contemporary extended septal myectomy, clinical trials, management of HCM in pregnancy, arrhythmia management, device decisions and management, and advanced heart failure and transplant. Thank you for attending Intermountain Medical Center's Live Strong, Big-Hearted Warriors Unite event. I hope we provided some helpful information about HCM and our program, and we look forward to taking your questions.
Thank you very much. Everybody can turn the cameras back on now. And oops, what happened to my screen? Okay, so we have our poll results that I want to bring to you. And to whoever, one of my staff members who was populating this, what is your relationship to ham would actually mean HCM, and I think I know who's guilty. I think it would be Julie because she's turning 14. Nope, it was Elle. Okay. So we don't want to know about what you think about ham. It's really hypertrophic cardiomyopathy. So if you were a little confused by the question, we get it. So I'm going to end the poll so we understand your connection to ham, and we're going to share the results and let y'all know who's here. We have the country coast to coast with predominantly West Coast represented. We have another country. I'm not sure where you're coming from, so maybe you can put the comment or use the chat box and let us know where you're watching us from. Always interested to see. Now, what is your relationship to ham, which is HCM, which is cracking me up. I'm a patient, so 67% of you are patients, but a few of you are patient and family member. Somebody here has a friend with HCM, and we have some medical professionals joining us tonight. So it's most commonly that you're going to be on medication, 58%. 25% of you are in the newly diagnosed group. We'll talk a little bit more about that later. 33% have a device, 17 have had an alcohol septal ablation or myectomy, 33% of you are an AFib, 25% have also lost a family member. We have a brandy new heart transplant patient on watching us, so that's fun, and somebody else with the transplant. So there's 3 of us in this room. And 42% have had some genetic testing. So it gives you a little bit of an understanding of who's here and where. Oh, I thought I was hitting share and you were reading along with me. I was reading it by myself. Now I can stop the share and the ham comment. Okay, we don't need to do that one again. Okay, so we have a nice big array from all over the place. Who do we have up next? Who is, let me go back up here on my screen. So we're just going to go over to Kia now. We're a little early on that one. I went quick on my little presentation today. I do want to say one thing before I go on, because I made a mistake on my screen and it got me all fumbled. I did not introduce the HCMA staff members who are here this evening. We have Julie Russo, our volunteer coordinator, and Valerie Ventry, our Center of Excellence coordinator. And I want to thank them for their assistance in launching and creating these programs with us. Julie is the person you will speak to if you do an intake or you want to volunteer for the HCMA. I will pop up a couple slides a little bit later and tell you ways that you can get involved with the HCMA. And I will give you an updated map on centers of excellence also, because we are up to 41 now. And I think you're missing a couple dots. We got to get you your dots. So Kia, we're going to talk to you about research in hypertrophic cardiomyopathy. So you can hit that magic share button. And
perfect. Let me get that.
You're unmuted.
I only have one screen, so it's going to take a second.
That's fine. Take your time. And once you do the screen share, then we'll get you, you're the Mac. So we'll get your Mac PowerPoint up. And while, yeah, you got it. And that's nice and easy. So as we get this going, and you are good to go.
Perfect. Thank you so much. Thank you everyone for joining. Thank you. So I'm going to talk about research in general, and then I'm also going to specifically talk about HCM related research, and then finally HCM related research at Intermountain. So HCM treatment targets. So Dr. Hebel mentioned beta blockers and calcium channel blockers, and those medications, as you can see, affect the outside of the myocardial cell, the heart cell. And those medications effectively were made for other reasons, and now we're using them because they happen to help some of the physiology and pathophysiology of hypertrophic cardiomyopathy and hypertrophic obstructive cardiomyopathy. But these drugs, the intention when these drugs were made was not with a patient with hypertrophic cardiomyopathy in mind. It was for other conditions, and now we just happen to have these in our toolbox to use in hypertrophic cardiomyopathy. So you see these in kind of circles or ovals, I should say. And then I put in rectangles medications that are now a little bit more specific, looking at the underlying abnormalities in the within the myocardial cell, within the heart cell, that hypertrophic cardiomyopathy patients have abnormalities in. I will talk about perhexylene as one of these drugs, which you see right in the middle. Aleclazine, which is a cousin medication of ranolazine. You see that kind of in the around 7 o'clock. And then around 4 o'clock, you see CY274 and mavacamten, two medications that we are involved in studies. And those are hypertrophic cardiomyopathy specific medications, and no other heart disease right now is being studied with those drugs to my knowledge. So the difference is now back in the day, it was drugs that affect the heart. And now we happen to use them for hypertrophic cardiomyopathy because we don't have really specific therapies. And the future looks like we're looking at these medications that are specific for hypertrophic cardiomyopathy patients in mind as the ones you see in the rectangles. So as I mentioned, beta blockers, and Dr. Hebel mentioned as well, calcium channel blockers. There's an antiarrhythmic medication out there called disopyramide, which we actually use not for the antiarrhythmic effects, but more for the potent ability to decrease left ventricular outflow tract obstruction. And then there's anti-anginal medications like ranolazine. These are all medications intended for a different purpose, but we use it in hypertrophic cardiomyopathy because it's kind of the best we got. We also have procedures, Dr. Hebel mentioned these: alcohol septal ablation, surgical myectomy, electrophysiological ablation procedures, which is different than the alcohol septal ablation, cardioversions, and also device implantations. That's kind of the pre-2020 and before tools we have in our toolbox. But as you'll see from research, as you'll see that research may provide us with more options in the future. So I want to first talk a little bit about phases of drug implementation so that people understand what it means to be in a preclinical or phase 0, phase 1, phase 2, phase 3, or phase 4 part of a drug development. Most people who are involved in studies will probably be in a phase 2 or phase 3. So if you really want to just ignore most of this slide, you can, and I'll focus mainly on phase 2 and phase 3, and all the studies I'll talk about after the slide are all phase 2 or phase 3. So preclinical means not in humans. It's usually animal studies that are large animals. I will say most of the time it's either pigs or dogs that they study to make sure the drug has an effect and no serious side effects that they can determine in a person, an animal that can't speak to symptoms, but as far as blood work and other things to make sure that it's not poisonous. Phase 0 is the first testing you'll have in humans. So this is, and it's usually a small group, and I don't joke about this, but it's mostly college students who are healthy, and they're just looking for obvious side effects. They've already studied this in animals, didn't see any, but now they're studying it in humans and make sure it's relatively safe, and they pay these people a little bit of money for them to volunteer for this. Next would be testing in patients. So by the way, phase 0, these are random college students who volunteered for this or are getting paid for this. They don't have the disease. These are just people who are going to take a medication for a disease they don't have. Then we have phase 1 studies, also small group, but now we're trying to look at patients with the disease and also trying to find kind of the right dose and where side effects might start coming in so that they can kind of understand that when we study this in a larger group, what dose should we kind of aim for, or what dose range, I should say, are we looking at? A lot of these studies will have, I wouldn't say a lot, but maybe half the studies that we look in phase 2 and phase 3 will have multiple different doses, or sometimes we'll use blood work to decide what dose is best in each individual patient. And those of you who have been in studies may know this, that a lot of times on your study visits, you have to get your blood drawn, and then maybe you'll get a few days later, you'll get a call to increase or decrease your dose. So phase 2 is, like I said, phase 2 and phase 3 are kind of the phases that most people who participate in research studies will be involved in. So this is kind of a more medium-sized group, so not the 10 to 20 range, but more the 20 to 100. These numbers are not absolute. I'm just trying to give kind of relative sizes. So very small, medium size, and then we'll go larger bit after that. So this is a medium-sized group. I say 20 to 100. I usually see the number somewhere around 50, 60, 70. And this is more extensive studying in patients with the disease to better assess the safety profile and dose scheduling. But they also do secondarily look at outcomes like improved symptoms, improved distance of walking in 6 minutes, maybe sometimes echocardiogram findings, sometimes other symptoms, how many times they get admitted to the hospital. But that's not the primary purpose of a phase 2 study. The primary purpose is for safety again, as well as dosing. But they will kind of look at secondary outcomes. This will not make or break the drug, and all of a sudden it will not skip from phase 2 to being on the shelf. You have to go through phase 3. But it does give you a better idea of what the phase 3 trial should be designed, or a better idea of what the design study should be in order to get the outcomes we want. So that's a phase 2. Now we're going to talk about phase 3. This is much larger. This is where a lot of money is spent. This is why there are phase 0, 1, and 2 to make sure that the phase 3 study is done with a lot of good information. So this is a larger study, usually 100 to 10,000. I mean, there are studies that are a little smaller and there are studies that are definitely bigger, but they're trying to grab a lot of patients with the disease to compare it to usually the standard of care, what people would consider, this is the default treatment for these patients. Now we want to test whether this drug, compared to that standard, makes patients feel better or live longer or walk farther or whatever outcome they decide is an important outcome to these patients. They will get a large patient study, and they will test the doses that they figured out from phase 2 in a larger study to compare it with the standard. And this is the kind of the make or break study for a lot of drugs that will either tell people that it's better than the standard, no different than the standard, and rarely will it be worse than the standard. Usually they'll figure that out at phase 2, but sometimes they will. Sometimes they'll say this drug actually makes patients feel worse. Then we do get surprised once in a while that a phase 3 study has what we call negative outcomes, but most of the time it's either neutral, minimally better, or significantly better. And that is what will make or break, especially a new novel drug. You know, many studies are studying a drug that's already been approved for one indication, and the drug company now wants to have it approved for another indication. It will do a phase 3 study for a new indication, but sometimes this is the first time the drug is ever being studied. And this will be the decision whether the FDA will approve this drug to be considered approved for use. And finally, we call it something called a phase 4 study. Phase 4 is after the drug has been approved, the FDA still wants to make sure that there's no significant safety concerns. So for example, imagine in a phase 3 study, we had 100 patients and there were no serious side effects that people showed up with. However, imagine now the drug is approved and now 100,000 people take it. And let's make an example, 4 people end up with needing a liver transplant for some reason. That would be hard to, 4 out of 100,000, you may not see that in a study that only has 100 patients or even 1,000 patients, but 100,000 patients and 4 need a liver transplant. And in general, a liver transplant only happens 1 every 10 million. The FDA wants to know that if that's happening. So even after a drug is approved, we still do gather data, especially when it's a novel drug being used for the first time in a larger group than the original phase 3 study. So based on this, I'm going to go to the next couple slides to explain a couple more things, and then we'll talk about the studies we have going on in Intermountain for HCM specific drugs. So you'll hear a lot about what we call the double-blind randomized placebo-controlled study. And I want to explain why this is very important and why patients sometimes don't understand why they don't get to know if they're taking the pill, or why they don't get to choose whether they want to be on the pill, or why there's a sugar pill even involved, because this is kind of the foundation of drug approval. We consider this the gold standard study to show that causation in medical studies. And so what do I mean by that? So placebo-controlled means that some patients get the study drug, the experimental drug, and some patients get kind of a sugar pill, something that should have no clinical effects, but you are taking a pill but it should have no effects on your body. It should be as if you're not taking the study drug at all, but they want you taking something so that you don't know whether you're in the experimental arm of the study or the not, the what we call the placebo controlled. And this is important. I'm gonna try to use the example of, let's say, the coronavirus vaccine. Imagine the Pfizer one or the Moderna one. It's important to be placebo controlled because you can imagine that a lot of people out there want a vaccine to exist and one that works. And so if they don't know whether they're taking the, imagine they knew they were taking the sugar pill or actually, let me put it a different way, sorry. Imagine we didn't have a placebo and everyone got the vaccine and no one got a sugar pill or a fake injection, if you will. Then we would never know whether the vaccine really has a true scientific effect or not, because it could be that the patients who happen to get the injection just live in an area that doesn't have high COVID rates. So we have nothing really to compare to when it comes to not using a placebo. But when you use a placebo, you can compare the patients who got the experimental drug with ones that didn't. And so that's very important. We know it has nothing to do with where they live. It happens to be that half the group got the known study drug and half the people did not. So we have a comparison. 2, why is it randomized? Well, almost for the same reason. We need to know patients can't choose which one they get because maybe patients who are scared of vaccines and don't want them to be approved will choose to be in the sugar pill arm or sugar injection arm, if you will. And those that want the vaccine to really work and they really think a vaccine is important will choose to be in the vaccine arm. And then at this point, now we have people who are motivated for a vaccine to be approved to be in one arm. And so we can't do that. We need to actually basically flip a coin to say, hey, these patients who have, of these demographics, half of them will have the vaccine and half won't. And these patients of these demographics, half of them will get the vaccine and half won't. So it's very important to have a random chance whether you get the experimental drug or you introduce what we call bias. And bias can really muddy the waters of scientific data to the point where we can make very bad decisions based on what we think is good data when the bias has now been introduced to the system. Blinded and double blinded. So when we say single blinded, that means the patient is not aware whether they're on the treatment or placebo arm. And double blinded means neither the patient nor the provider knows whether the patient's on it. And that also takes away bias. Imagine you have a patient who really wants the vaccine to be approved and gets the injection, may minimize complaints because they don't want to say that the vaccine's bad. And so they may just not complain of coronavirus symptoms, if you will. And same with a provider who really, really wants a vaccine to be approved may not say that their patient's symptoms are consistent with COVID because they don't want potentially a patient to show that the vaccine is not effective. And so bias is huge. It's sometimes it's intentional and sometimes it's subconscious bias that occurs. So the best way for us to have a scientific causation study, a clear cut, is to have a randomized, double-blind, placebo-controlled study. And that's why we do it. And as a patient, sometimes you will get the sugar pill and you will not get to choose if you're going to get the study drug or not. And you will not know during the study whether you're on the drug or not. And we won't even know if you're on the study drug or not. And sometimes we guess, we're like, oh, the patient says they feel better. And lo and behold, the patient thinks they're on it. We think they're on it because the patient says they feel better. And when we open up the envelopes at the end of the study, they're actually not. They got the sugar pill. So that's another reason why we have to do the study this way, is because of that bias. And this has happened many times where the provider is convinced that the patient was on the study drug when they weren't. So I know it took a long time with that slide, but I think it's kind of important to understand that this is the way almost all high quality studies are done in order to prove causation in medical studies. So now I want to talk about HCM specific treatment options that I think are going to occur in 2020 and beyond. These are now medications specifically looking at HCM diseases, physiology and pathophysiology. Now, these two are grayed out because these are studies that are either completed or we're not involved in. There's a medication called perhexaline, which we were involved with a previous study of theirs, and I think that got stopped, from my understanding, for financial reasons. The company was running out of money, so now I think this is maybe kind of a repeat of that study. So what this study looks to is a phase 2 study, so medium-sized group, study drug versus placebo, and they're looking at how the left ventricle, the thickness of the wall of HCM patients, if the size of the thickness goes down at 12 months in patients who have symptoms. So it's kind of a imaging endpoint study. Eleclazine was a study that is no longer being done. It's already been completed, and it was looking at exercise capacity in patients with HCM, and it was also a placebo-controlled study. Most phase 2 and phase 3 will be placebo-controlled. Now I want to talk about 2 studies that are going on, and Intermountain Medical Center is involved in both these, which we're excited about. Mavacamten, which is a myocardia drug. Myocardia is the company. The name of the study is called the Valor HCM study. And it's a phase 3 study, so a larger study, clinical trial. It's study drug versus placebo in patients with symptomatic obstructive hypertrophic cardiomyopathy. So people who have LVOT obstruction who meet the criteria that they need either surgery or an alcohol septal ablation, meaning that they have symptoms that the standard of care medications are not relieving, and they have high gradients, and they're good candidates for a septal reduction therapy of some sort. You get randomized to study drug versus placebo, and they want to assess whether at 16 weeks you still need that surgery or procedure versus you don't. There's other outcomes, but this is the primary one, that at 4 months, imagine you get put on the study drug and you feel so good, you're like, I don't want the surgery anymore. And so we say, oh, that's great. You don't want the surgery anymore. Let's keep you on the drug for a prolonged period of time. Or you may get study drug and still need the surgery. You may get placebo and at 16 weeks not want surgery. And then you may get placebo and at 16 weeks still need surgery. And so after we open up the envelopes, we try to see how many people are in those 4 boxes. Study drug needed surgery. Study drug didn't need surgery. Placebo needed surgery. Placebo didn't need surgery. And see if there's a big difference between those that needed it and those that didn't. So 90% of the people on the study drug, for example, didn't need to go on to surgery, but 90% of the people on the placebo drug did need to go on to surgery, we would say the drug's pretty darn effective. However, if 52% of the patients on study drug needed to end up going to surgery, and 49% ended up, and the placebo ended up needing to go to surgery, well, then we'd say the study drug maybe have a minimal help, but not enough to think of it as being a drug that we want to move forward with in larger populations, and or is worth the cost when it only improves it by 2 or 3%, because even the 2 or 3% may not even be real. It may be, if the patient happened to be on the other side of the study, it may have been 50-50. So if you flip a coin 100 times and you get 51 heads and 49 tails, it doesn't mean necessarily the coin is uneven. It may be a perfectly normal coin, but it just happened to go 51-49. So we look for a significant difference between the study drug and the placebo drug to assess whether it's a beneficial therapy. The next study I want to talk about that we're involved in is CK-274 is the name of the drug. Usually the drugs start off with these names when they're in the early stages of research, and then once they become around phase 2 or phase 3 trials, they get a name that they stick with them for the rest of their life. So this is Cytokinetics is the company that has made this drug, and their study is called the Redwood HCM study. It's a phase 2 clinical trial, so a little bit smaller, study drug versus placebo, and they're trying to study the effect of doses in patients with symptomatic obstructive HCM as well as side effects. But they're going to look at secondary outcomes as well and see how if patients have improved exercise tolerance or symptoms or hospitalizations and things like that. So it does look at outcomes, but it's not the primary purpose of the study. So I want to talk lastly about the pros and cons of participating in research studies. So the potential benefits or pros of participation, one is you contribute to science and medical research. 2 is you have the benefit of potentially having access to a novel medication that may not be available for years. I would only want to say months. It's probably on the order of years before you have access to that medication. So if it happens to be a medication that helps you, then you get the bonus of being on it years before others. And a lot of these trials actually, if they're proven to be safe, you have the ability to have continued access to the medication after the trial is complete, but before it's approved. So imagine the trial is complete in 2018, but it doesn't get FDA approved in 2020. A lot of times the drug company will allow patients to be, as long as it's safe, to be on the medication for those 2 years while they're going through the approval process. And that's usually, and I wouldn't say usually, it's almost always every patient in the study. Even if the patients were on the sugar pill during the study, they get access to the medication after the study is complete before the FDA approval. They're potentially exposed to a treatment that can start a reversal process earlier. So if a medication actually reverses the process, imagine that perhexylene drug causes the thickness of the heart to regress, you get to be on it 2 or 3 years earlier, and you get to start that process of regression before others, or not before others per se, it's not about other people, but you get started early in your life. So you maybe get to start at age 42 instead of 46. A lot of these drug studies will pay for costs of routine tests that you normally would pay for, or you would have to have your insurance pay for it. And then finally, sometimes there's a reward as far as travel and even non-testing reimbursement. So travel testing gets reimbursed, but sometimes there is actually a stipend for being in the study. There are potential disadvantages. You could potentially get randomized to the sugar pill arm of the study. And that's not the end of the world because you may have access to medication after the study is complete. But you may go through the study and not get the actual study drug. The study drug may not be effective, or even it may have negative effects. Maybe some negative effects won't pop up on phase 1 or phase 2 that actually you get side effects from, or significant side effects from during the phase 3 study. And finally, you tend to have to go to more frequent visits. These studies want to make sure that no stone goes unturned, and they will make you come at pretty regular intervals, more than what we would consider the standard of care. So maybe we see patients every 3 months. The study may want you to come every 4 weeks. And so there is a time aspect of this. So in summary, we are participating in 2 randomized control studies at Intermountain of 2 very exciting novel drugs for myocardial and cytokinetics. And that's kind of the nuts and bolts of research studies in general, and especially HCM specific research studies. Thank you very much for your time.
I'm coming. I was working on another screen while I was listening to Kia talk, and I was so enthralled with his talk, I just was taking notes someplace else. So thank you very much for that excellent presentation. I'm going to jump back and go through some quick slides that I kind of meant to do at the beginning of the talk today, but then we got all excited with my little flub up in the beginning. So I'm going to do a share screen here and just go through a couple of services of the HCMA and let you guys know a couple of projects that are coming up that you might want to be involved with. And also to give a huge shout out to our sponsors, which I forgot to do at the top of this meeting. And that is Myocardia, which we were just hearing about, and Cytokinetics as well, Boston Scientific, and Invitae. And then just a reminder that the Invitae genetic testing panel is still available free of charge to anybody who has hypertrophic cardiomyopathy diagnosis and their families for screening. And you can get information on that on the front page of the HCMA website. And I do have to say that that program and their sponsorship of this event are not tied together in the least. They are completely separate entities. So that's an opportunity. For those of you who are watching while we're streaming on our social media channel on Facebook, I don't need to tell you that we're on Facebook, but for those of you who are elsewhere watching this, maybe YouTube later on after the presentation has been uploaded there, you can join us on Facebook for events like this one and others through our regular Hypertrophic Cardiomyopathy Association page. I encourage you to like the page. We're a few members away from another milestone number, and I like my milestone numbers, nice big round numbers. So share it, send it to your friends, have them like our page, they can follow what we're doing. Associated with our group are two private groups. One is for parents, it's the HCM Parent Communication Network, and then we have the HCMA Private Discussion Group. You're going to see more of these groups popping up in the coming months as we are branching out to cover other countries through a project called HCMAI. HCMAI, the I stands for international. So we're working with partners in other countries. If you're watching this from another country and you're interested in starting a patient support group for your country, please contact us and we'll help you get set up. And then we'll help you link your main page for your Facebook group to our page so that we all are communicating and we're all using the same data and working together to get further faster. So you can join us in any of those discussion groups. Starting on Tuesday, this Tuesday, we're going to have our first ever online support group. The topic for this one is pre-myectomy, which means you will have already had to set your date with your surgeon to participate in this group. If you are saying, oh no, I didn't do that yet, it's okay. This is going to be a monthly feature. Second Tuesday of each month will be pre-myectomy Tuesdays, followed and including first Thursdays of the month will be newly diagnosed, which counts for your first 2 years. I will be running those groups. We have 13 amazing trained HCMA volunteers who are going to be running a lot of different groups. I want you to think about them like radio stations and their DJs back in the day. I know I'm dating myself a little, but you're going to see that each room has a different feel and a different theme and a different way of approaching issues of importance to the HCM community. We will be inviting speakers to come into the support groups for the coming months. The first couple will just be you and the group leader. Then we'll be bringing in key speakers to cover topics. Maybe you'll have a genetic counselor come in, talk about genetic counseling. Maybe we'll have a physician come in, talk about need for ICD. We're going to have all kinds of different topics. There are going to be about 23 plus opportunities per month for you to participate in. Groups are limited to 25 people per group, and these groups will, like I said, cover a myriad of topics, and nobody should ever be more than a few hours away from support from your peers. So that we're really excited to finally get this up and going. Okay, other programs, we're working on our peer-to-peer Big-Hearted Friends Network. Think of us as the eHarmony of HCM mentorship. We're going to be starting to recruit for that next year, which is only a month and a half away, but look for that around mid-year next year to be launched, but because we're working on a couple of other projects at this time, but this one will be coming up soon. We're looking for the Share Your Story participants for our brand new coming in hopefully February website, which is going to be a complete retool, first time since 1995 that we took it down to nothing and we're rebuilding it from scratch. February is also the 25th anniversary of the HCMA. I don't think I'm quite old enough to have founded the organization 25 years ago, but the calendar says so. So there we go. We're going to be using your stories in the new website in much more integrative ways. So I would encourage you, if you're interested in sharing your story and maybe going on videotape for us to talk about it a little bit, contact Julie at julie@4hcm.org and she can get you in our Share Our Story system. We are truly at this point looking for a couple of different demographics to be represented because we know you're out there. We need basically people of color. We need people from the Latino community, the African American community, the Islander community, Asian community to come forward and share their story. We have a lot of Caucasian stories and we want to be sure that we're representative of the entire demographic of those with HCM, which is basically everybody. If I missed your demographic, I apologize. We need everybody. We need diversity. We need to show that HCM is as common as the different faces in a crowd. So please consider sharing your story with us. We have a legislative subcommittee that's going to be training some legislative advocates for efforts coming up in the coming year. If you're interested in participating in becoming a legislative advocate, email us at, you can just call Julie. She's our volunteer coordinator. She'll get you set up for training that's coming up in a couple more weeks. And then we're going to start to try to change some laws, specifically including cardiac components to well-child screenings. Nothing controversial, bipartisan efforts. We want to protect families' hearts and we want to make sure that everybody has the tools to know that their families' hearts need to be checked. So we're going to start with that effort and we have other ones underway as well. If you have not watched the patient-focused drug development meeting, it's 4.5 hours. I know it's a little bit long, so you might want to pop around and see some of the comments that are being made. I don't want to start the video. I'm going to move to the next screen, but you'll also get an idea on some of the programming that we're going to be looking to put into the new website because it's going to have very much that look and feel. I want to thank everybody for participating tonight and remind you all that we still have our free 23andMe kits to give away. If you are an active paid member of the HCMA, you are eligible to receive a free 23andMe ancestry and health kit. It has nothing to do with HCM genetic testing. It was a gift in kind by Myocardia, who got it as part of a deal that they made with 23andMe. They donated them to the HCMA for distribution to our members. There's nobody's else is going to get your data. It's just 23andMe kit that you could buy online, but because you're a member of the HCMA, you can get a code to get one for free. So claim them, please. They're available. We have plenty for everybody at this point, and it's one per family. So I want to thank everybody for their participation tonight, and our staff and our great faculty who are spending their time here tonight. And I just wanted to make sure I got those points across because I forgot to do that earlier. Okay, so I stopped sharing my screen and now I have to go back to my agenda. And I'm going to do this because I do this. Sumati, did I say it right this time? We're going to hear about some genetic information from you now. And did I get it right?
Yep.
Oh, good. I'm very happy with you. I get the names right.
You did.
So I pass it off to you and you can share your screen whenever you're ready.
Awesome. I'm gonna try doing that right now.
This is one of the few groups that we've worked with that Zoom wasn't their main platform. They're a WebEx group, so they're I think our Teams, one of them. And if you're not used to the format, it's like, oh, it's a whole different landscape. I guess it's kind of like Mac and PC. That works.
Okay.
See the eyes darting around the screen.
I'm sorry.
That's okay. So we have a comment here that I'll read by an anonymous attendee that they're approaching their first septal myectomy at Mayo and grateful for everyone who took part in giving you the best treatment in the world. A year later, still struggling with some diastolic dysfunction. You got a lot going on there, my dear. You're 80 years old and thankful for all your days. Well, we are very happy that you're here with us today. I hope that the rest of your medical journey gets a little bit easier for you, but I'm really glad that you had a good experience with your myectomy and wish you best of luck.
I'm not sure why it's.
So at the bottom of the screen, you can see this share screen option.
Okay, yeah, there it is. Are you able to see that?
We are. Now you just have to put yourself in present mode and you're good to go.
I see. All right.
I'll make you guys Zoom pros if it kills me.
Did that work?
You want us just switch the display settings because we're looking at your version, not the display.
Oh.
So now just go to the top setting where it says display settings, the top of the screen. Show taskbar, display settings.
Yes, yes.
Click that.
And just swap.
Swap.
Okay.
Yes.
And did that work?
Not yet.
Huh.
I don't think you clicked swap because it's still
Or
highlighted.
did I not? How about now?
Nope. Try again.
Wow. Okay. That's a little bit weird.
Honey, it's 2020. There's a lot of weird stuff going on. So don't worry about it.
I want to say I tried this multiple times to make sure it was working.
Of course you did.
But here we are.
So let's try that share screen again.
Share screen. It's very rarely not even showing.
You have to hover over it so you can see it.
All right.
You got this. I have faith in you. It's okay. I can tell stories.
That sounds good because yeah.
Okay, so I'll tell the story about how for some very bizarre reason, when my calendar gets set, which is set by somebody other than me, normally our intake coordinator, in this case, Julie, for whatever the reason, there's always a theme of the day and they are random. So it's all myectomies one day, it's all ICDs the next day, it's all transplants the next day. It's just really fascinating that somehow fate puts you all together in my books. Okay, so now all we have to do is hit your display on the bottom. From beginning up, you can click that one. And now display, drop down one. You gotta see the drop down.
Okay.
Swap, click.
Swap.
Swap.
I did that. Did that
And
work?
now it works. You're on.
Okay. All right. Perfect. All right. So sorry for that technical issue there. But I'm Sumati Rachmadagu, and I'm one of the cardiovascular genetic counselors with Intermountain Healthcare. And I'm very glad to be with you, all of you, this evening to talk about genetics and how it relates to HCM. And through the course of the talk, I'll present information that I hope will help you recognize the role of genetics in HCM, um, help you learn about the benefits of genetic counseling and testing for HCM, as well as highlight the unique aspects of receiving care to the genetics team at Intermountain Healthcare. So we'll start with some genetics overview. And I suspect a lot of you already understand most of this. So hopefully this is not a lot that I'm covering that you already know. But every gene has a code on an instruction for a particular structure or function in the body. And just like a spelling error in a sentence can change the meaning of that sentence, as you can see in the example here, there's a lot of difference between a sentence that says my health is important to me versus my wealth is important to me. In the same way, a change in the genetic code can then prevent the body from getting the proper instructions and then go on to develop disease. Now, it's important to note that not all genetic changes will cause disease. Those that do cause disease, we call them a mutation. And humans have multiple genes that are important for heart muscle structure and function. And having a mutation in some of these genes can cause HCM. So what does genetic testing for HCM involve, and what are the types of results that we can come back with? Over the years, several genes have been identified to cause HCM. Some of these genes only affect the heart and cause HCM. Some genes can, in addition to causing HCM, cause additional features elsewhere in the body, and we call them as syndromic HCM or HCM phenocopy conditions. And most of the time, when an individual is undergoing genetic testing to identify which specific gene has caused HCM in them, they undergo what we call as a panel test, where most, if not all of the genes that we currently know of to cause HCM are tested all simultaneously to look for a mutation. And it's also important to note here that not every person that has a mutation, has HCM and undergoes genetic testing will have a mutation on the test. Up to about 60% of the time, we end up finding a mutation. And so when an individual has a mutation, then we say that their genetic test result was positive. They have a positive finding on the test result. And the times when there is not a mutation identified, it could be one of two result types. The individual may only have genetic changes that are benign, meaning they don't cause disease at all, in which case they would receive a negative genetic test result. And sometimes they may have one or more genetic changes that the scientific community does not understand at this time whether that change is disease causing or not, and they classify that as variants of uncertain significance or VUSs. And you'll notice that the positive and the negative category are further, there are two other categories that fit into each of those. Genetic changes that are pathogenic or likely pathogenic, that is definitely disease causing or likely to be disease causing, both fall under the positive category. And then we have benign and likely benign under the negative category. Now, as and when evidence becomes available regarding whether a particular genetic change is likely to be causing disease or not, that change can get reclassified. For example, maybe a genetic change was called as a VUS, but over time we've learned that multiple individuals with HCM or even families with HCM has this particular VUS, and then we were able to upgrade that classification of that genetic change to a positive result. But a lot of the times, VUSs actually get reclassified to a negative result. And it's just important to know that it can take many months or sometimes even many years to gather that evidence and data to be able to reclassify a genetic change. So what about the HCM patients that undergo genetic testing and don't have a mutation identified on the test? Even when a mutation is not identified, we expect that HCM is still a genetic condition, and we hope that research over time will be able to identify those missing genetic contributors to HCM. So how does HCM run in families? Most of the time, HCM follows what we call as autosomal dominant inheritance. And in that inheritance pattern, all close relatives of an individual with HCM, so that is parents, siblings, and children, each of them has a 50% chance of having inherited a familial mutation that can then put them at risk for developing HCM, regardless of gender. And they have a 50% chance of not having inherited that mutation. But there's a lot of variability that we see in how HCM presents within and even among family members. So if we take a group of individuals that all have a mutation, we'll see that the majority of them will go on to develop HCM at some point in their life. But there are some people you can see in gray in that cartoon on the left, they never develop HCM. And among those that go on to develop HCM, as Dr. Hebel already mentioned, the presentation can just be so variable. It can happen at any age, and it can be on a spectrum all the way from mild to severe. So with that background information in mind, let's talk about what the various genetic test result types mean and how they can be helpful for our HCM patients and their families. So whenever a patient undergoes genetic testing on a panel test, like we said, there are 3 types of results. Most of the time when a patient is undergoing genetic testing, regardless of the type of results that is obtained, it doesn't tend to change their own medical care. There are a few situations where it might. An example is, let's say there's a patient in whom there's a borderline diagnosis or there's suspicion for HCM. Maybe the heart test shows some findings that could mean they have HCM, but it's not very clear. And a mutation is identified on their test, and that would confirm their diagnosis, would confirm a diagnosis of HCM in them. But whenever HCM is identified in a family, the important piece is that we can now use that information to test family members to say which of them is at risk for developing HCM and who is not at risk. So family members who also have the mutation are at risk for developing the condition. And we recommend that they get their hearts tested periodically to look for signs of HCM. We call this HCM screening. And the hope is that, we will be able to catch the disease at an early stage, and we'll be able to initiate treatment early on if they do develop the condition, and that this may slow down progression of disease or prevent progression of disease, and in some cases prevent sudden cardiac death. Now, in family members that do not have the familial mutation, then they're not at risk for developing HCM, and they don't need to be screened periodically. Sometimes, of course, we don't know the cause of HCM in the family. Maybe the genetic test was negative or identified a VUS, or maybe the patient declined genetic testing. In all these scenarios, we don't know the genetic cause, but we expect a genetic cause. And we can't use genetic testing to predict which family members are at risk. And instead, we recommend that they directly proceed to start undergoing HCM screening so we can still pick up the condition at an early stage if they do develop it. And what does the HCM screening involve? At a minimum, screening involves a physical exam, echocardiogram, and an EKG. And if the initial screen is normal, the screening needs to be repeated periodically because we know that HCM can develop at any age. And the hope, like we said, is that with regular screening, we can give patients the right care, and that in turn will help them live long and healthy lives. And I also included on here the screening frequency that is recommended by the Heart Failure Society of America for the family members of those with HCM. And you can see on here that screening begins early in life and is periodically repeated throughout the lifetime of an individual who is at risk. It's, however, done more frequently when, in childhood, and then the frequency tapers off as the individual grows older. So when I talked about genetic changes, how they are classified, how we interpret them, and how over time those can be reclassified, I think that may have given you a sense of how complex genetics and genetic testing is. The point that I want to make here is that because it is so complex, it's important to have a specialist team that includes individuals that are trained in and have knowledge of genetics so that you are receiving the right care. And this cartoon here, I really love it. And I think it speaks to this complexity that I've been alluding to. You have DNA talking with his or her psychiatrist and saying, "No one understands me." So what is genetic counseling? Genetic counselors are those trained specialists that are the ones interpreting genetic test results and ordering genetic test results. And ordering genetic testing. And at Intermountain Healthcare, we have a great group of genetic counselors. And all of us are trained at a master's level, and we receive training not just in genetics, but also in relevant counseling techniques. And whenever a patient is diagnosed with HCM, then our cardiologist will refer them for a genetic counseling appointment. And we then meet with the patient in an initial appointment where we gather their medical and family history and review that information, which then helps us decide the disease characteristics in the family. Is this likely to be syndromic or not? What's the inheritance pattern? Who are the relatives that are at risk? And using all of this information, then the genetic counselor chooses the best test and also identifies who the most appropriate individual in the family is to start testing with. In that initial appointment, we also provide education regarding HCM and its inheritance. we discuss the benefits of HCM clinical screening in relatives who are at risk. We discuss that genetic testing is recommended for anyone with HCM, and we also go over the benefits and limitations of undergoing genetic testing. We also talk about the various test options that are available. Like Lisa mentioned, there are free test options. So we talk about, what are the benefits of one type of test versus another type of test? Is insurance likely to cover it or not? And then, because genetic testing is a personal choice, if the patient decides to undergo genetic testing, we order the test. If the patient decides that genetic testing is not for them, then HCM is still genetic condition. So what we do is we give the patient a family letter and encourage them to share it with their at-risk relatives, so family members can go ahead and undergo HCM screening. So if the patient has decided to undergo genetic testing, then once the results are back, we work closely with our cardiologists, and we interpret those results and come up with the next steps or an action plan for the patient and the family members based on those results. And then that result and those recommendations are communicated to the patient. And again, we make sure to give the patient a family letter that will recommend starting with genetic testing if a mutation was identified in the patient, or straight away starting with HCM screening if we don't know the cause in the family. The genetic counselor also throughout this entire process is assessing for any psychosocial issues that may come up. Maybe the patient has concerns about genetic testing, anxiety about genetic testing, or is having a hard time coping with their diagnosis. The genetic counselor will help the patient process these concerns, and also help them connect with other resources that can also further support them. And we talked about reclassification of results. If that ends up happening, then the genetic counselor will call out those results whenever the reclassification happens as well. So coming to some of the unique aspects of genetics related care at IHC, one I will say is the collaborative relationship between our pediatrics and adult clinics, which fosters family-centered care. Now, as Ashley already mentioned, all of our adult patients, actually most of our adult patients are seen at Intermountain Medical Center in Murry, Utah. However, the children in our HCM families are seen at primary Children's Hospital, which is also part of Intermountain Healthcare and is in Utah. But it's important that because family members are being seen by different providers at different locations, that there's communication between them, so we can make sure that everybody is getting the right care and the most appropriate care. For example, sometimes we find mutations where the disease presentation may appear very mild on certain tests like an echocardiogram, and maybe a cardiac MRI is needed to go ahead and accurately make a diagnosis. And so that information is then communicated to both the adult providers and the pediatric providers to make sure that every single family member is getting the right testing. Another unique aspect to care at our center is that in addition to face-to-face genetic counseling services, we also provide telehealth services. So patients and family members needing to undergo testing can have the process coordinated from the comfort of their home. And what this also does is that it enables us to track the presentation of the disease in the family better, since we're also able to offer these telehealth services to people living out of state most of the time. A third unique aspect that I'd like to highlight is the opportunity for involvement in research to help understand HCM better and its genetic causes better. Dr. Afshar already touched on several research and endeavors that are looking to improve treatment. But I wanted to highlight from a genetic standpoint that Intermountain Healthcare has collaborated with Decode Genetics, and we're doing a population study called as Heritogene Population Study. We're enrolling 500 individuals to help answer questions about several inherited conditions in addition to HCM. And I had some case examples here, but we'll skip in the interest of time. So in conclusion, genetic counseling along with genetic testing can be beneficial for the patient as well as their relatives. When a mutation is identified, we can use that to predict which family members are at risk and need screening and those who don't. And when a family member tests negative for a familial mutation, that can relieve their anxiety regarding risk. At Intermountain Healthcare, the care we provide is by a specialist team. It is family-centered care with collaboration between our pediatric and adult care providers. And at Intermountain Healthcare, there are opportunities to participate in research. And that concludes my talk.
We're not letting you get away that quickly because as you were speaking, of course, all the genetics questions start popping in.
Oh, really?
So this is good. Okay, so they're both kind of the same type of question. And that's one of these situations that we see oftentimes getting a little bit confusing for some families. So number one, there's a gentleman who actually he's a Jersey boy because he was talking about where he was originally diagnosed with HCM in 1984, gone through devices and a heart transplant. And now he says, but I don't have an identifiable gene. So his thought was, I don't have HCM. Could you please discuss what genes we know and what we don't know? And if somebody had a diagnosis for 3 decades and moved to transplant, they probably really did have HCM, but not a known mutation. Want to explain that?
Yeah, I can attempt to explain that. You're absolutely right, especially with someone that's had such severe disease. We would strongly suspect that there is a mutation. And like I touched upon here, up to 40% of the time, and that's quite significant, we don't find a mutation. And we're learning all the time, and the genes that we've discovered thus far have been discovered over several years, and it may take a few more years for us to understand all of the genetic contributors. So I would say, even if your genetic test is negative, we have definitely seen families where clearly there are multiple people that have HCM and it's genetic, but we don't find a mutation. So there's a lot of evidence to say that there's got to be other genes out there that haven't yet been discovered. Yeah.
So the
I hope
next,
that answers.
so I think you answered it. We'll see if Robert thinks you answered it. So you can comment, Robert, because you asked the question. It's a family affair tonight at the HCMA, and that's perfectly fine. We had a baby in the last meeting, so we get it. And we really appreciate you guys all sticking in their COVID style at home doing these important meetings. So Elizabeth asks the question, so our son's genetic test came back negative. Should the family members get genetic testing? And I'm going to step on the soapbox of Lisa's pet peeves. I hate when the term negative is used to explain a genetic test result. It's not a positive or a negative. It's a mutation found, not found, variant of unknown significance, and all of the things we were talking about in your talk. So can you tell this family, and I'm going to make an assumption here, that the son is the one who has phenotype clinical hypertrophic cardiomyopathy, and he was tested and he didn't come up with a known mutation. So what should a family do in that scenario? And Elizabeth, if I've gotten any of that wrong, please type in another question. Off to you for an answer.
Okay. Yeah, again, that is a great question. Just like I said, we don't always find a mutation, and you have a young kid that's affected with HCM, and there's nothing else that is found that is contributing to that HCM, and that means it's very, very likely to be genetic. That being said, genetic testing is most appropriate to start with in a person that actually has the condition. And now that we've tested him and he doesn't have a mutation, what we can interpret from that is that he likely has a genetic change that is not going to be identifiable on current genetic testing. It's probably something that still needs to be discovered. So that being the case, testing family members with genetic testing, you're going to expect that they're going to come back negative, even if they actually have the risk, because we're not going to identify it on current genetic testing. And we may end up doing a disservice to those family members, saying, well, you don't have a mutation, so you don't need to be screened. And I agree, the terminology negative is not very appropriate, but that is the result that comes out on the report. And as Lisa mentioned, a negative result does not mean that the HCM is not genetic. It just means that we're not able to identify the mutation at this time.
At this time, we always learn, and that's why we always suggest when you go back to your HCM Center of Excellence where you're getting your care, we hope that you ask your clinician team, has there been any changes to my genetic testing results, either a change in the status from a VUS to a pathogenic or in the opposite direction, or are there new genes that we're looking for that weren't here 3 years ago? But every about 3 to 5 years is a good time, we think, to kind of check in and say what's new. But you never know when something new is going to pop up, so it doesn't hurt to ask the question. So, okay, so
that's a great point, Lisa. Yeah, we're always identifying new genes. So
we are, and I'm going to address another question that was posted in the chat area here, which was about an article that was published just a couple of weeks ago out of the Share Registry about predictive value of myosin binding protein C mutations. I don't know if you saw that article yet. It's still relatively new. It's interesting. It's a little provocative, which I love about HCM. Nothing is always just like, oh, of course. It's always like, well, it depends on how you slice that one. The Share Registry is claiming that with myosin binding C mutations, depending upon the type of mutation, you can actually start to use it for clinical decision making because they're so predictive, which I think we're getting to a point where that might be the case. And this is early data from like 7,000 patients in the Share Registry, and they're claiming that they can make this association. But I think we still need to kind of put that into practice a little bit. Docs, you want to comment on this one? Have you seen this article? Any thoughts? Kia, Virginia?
So, Kia here. So I have not seen this article, so I'm going to see it soon. As Lisa mentioned, a lot of these are provoking. As of 2020, we're not supposed to use the specific, either the gene mutation or the specific genetic change to make clinical decision making. We use predictive models that are more imaging based and family history based and personal history based to make our decisions on. The big decision is the defibrillator versus no defibrillator, or defibrillator now versus defer the decision later, I should say, based on the way your heart looks, your family history, your personal history. So the current guidelines do not recommend using which gene or the specific mutation. That being said, amongst people with HCM, and certain mutations do behave differently and certain genes do behave a little differently. We kind of know that, but nothing has beaten the models that we already have in our guidelines to tell us what we should do. However, my guess is, years, if not years or decades from now, that may change. The more and more we learn and the more patients get in these studies in the Share Registry, as well as our study with our genes at Intermountain Medical Center, we might understand much better when we have a much bigger population. If we have 100,000 people and we notice that every single patient or a high proportion of these patients do have malignant arrhythmias and patients without this gene mutation tend to not have it, well, that may become a part of our decision-making model. But as of 2020, the guidelines do not recommend using the gene or the specific mutation in our decision-making models.
Thank you. Couple other genetics questions. You never know who's going to be the hot topic this night. How often is the cost of genetic testing covered by insurance? Well, right now, you don't have to worry about that because you can use the Invitae panel and it's free to everybody. So everybody's wondering, okay, there's no free lunch. What's the cost? I'm going to explain it to you real easy. There are a couple of phenotypes that look like HCM, but actually genetically are another disorder. And some of these other disorders have very specific treatments now. There's drugs that are targeted specifically at things like amyloidosis. There's a new trial for a drug therapy for Dannon's, for Fabry's disease. They have their own treatment pathways. And frankly, they're really expensive. And they look like HCM. So these patients kind of hide sometimes in HCM centers. So the sponsors of those drugs are willing to pay for HCM genetic testing to find these very rare 1-2% individuals who have these other disorders. The cost to the patient is actually nothing. The cost to the provider who writes the prescription is they're agreeing that if you have one of these mimickers or these phenocopies, that they can contact the doctor and say, regarding these test results, we have a therapy for that patient. That's the cost, is a pharma call to the doctor who ordered the test. So no, there's no free lunch, but in this case, you don't have to pay for it no matter what angle. The doctor needs a little bit of their time to accept a phone call or a written correspondence offering them information about the therapy that they have for that genetic mutation. So that's the cost. Your name is blinded from it and your name is not included in that. They just want to make the doctor know that the therapy exists. So you can get that for free right now. But going back to if we didn't have this plan, because it could go away tomorrow, we're not guaranteed that this is going to last forever. But if you wanted to get it today, are you having any pushback through the payers that you see at Intermountain on getting genetic testing paid for when you need to?
HCM genetic testing is recommended by several scientific communities, including the Heart Failure Society of America. So what that has done is it's made it easier for us to ask insurance to cover genetic testing. And I'm going to say that people that have select health insurance, which is a significant population of patients that receive care through Intermountain, the select health policy is to cover genetic testing for HCM. If it is a different insurance, when we send off the genetic testing, the laboratory actually helps us figure out whether the insurance is going to cover the test or not. And then that information is relayed to the patient. So you're never undergoing the genetic test, without knowing whether it's going to be covered or not. You may end up paying more for the test if you have a high deductible though.
Yeah. And the tests, when the first clinically available test for HCM hit the market, I'm going to make myself sound old again. It was about 2005 and it was $8,000 for like 4 or 5 genes. Today, you can get a panel of, oh gosh, help me, what's it, like 80 different variants and genes for somewhere in the neighborhood of $1,500 if you were a cash pay, roughly. So the number of genes that they're looking for has gone up and the price has gone way, 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 way down. So with the free program, it's even better, but it tends to be covered nowadays all over the country if you're not watching from, Utah. So you will find that most of them would get covered, but there are these free programs available. So now comes a trick question. I will get to the guidelines question in just a moment, but I think this one's really interesting. My father has dilated cardiomyopathy that expressed later in life, 70 plus years. My mother never got genetic tested and has no symptoms, and she's 89. All three of my siblings and I have HCM, 100% penetrance in this generation. Should mother be tested for HCM is the end of the question, but I'm going to add in, or does dad have burnt out hypertrophic cardiomyopathy and mom can just be 89 and fabulous? Who wants it? Kia unmuted first. She beat you, Virginia.
Oh, yes, what you just said. I think that's the more likely scenario, is that the father, as Dr. Hebel mentioned and can comment on, about 3 to 5% of patients with HCM will go on to have what we call systolic dysfunction, which can look a lot of like dilated cardiomyopathy, or dilated cardiomyopathy can end up having systolic dysfunction. And we may have just missed the asymptomatic hypertrophic cardiomyopathy phase. It's probably more likely, but Sumathi and Dr. Hebel can respond as well.
Okay,
Yeah, I would agree that scenario is definitely more likely, but if you wanted to be thorough, it's not a bad idea to test mom to see if she has HCM. And the other situation that we should also consider is that did dad really have DCM? Because many people can develop cardiomyopathy for several other reasons.
Yeah, I agree. There's a lot to be sorted out there. And sarcomeric gene mutations can cause HCM and DCM sometimes in the same family. So it can get very complicated.
Yeah, that's, I know there's many of the myosin binding protein C mutations and a couple of the myosin heavy chain mutations that can show up as either dilated cardiomyopathy or hypertrophic cardiomyopathy, which sounds so counter logical. It can cause a thick heart and a thin heart. It's just causing a muscle disorder. And if you think about it more as a muscle disorder, not thick or thin, it makes a little bit more sense. So dad may have been a hypertroph undiagnosed, which there are a lot of, until his heart function went the other way. So I would think, and chime in here with me, if you wanted to do genetic testing, any of those of you with HCM can get tested and then see if dad has the same gene through the panels we were talking about earlier. If dad does not have the same genes as you, go check mom. And to paraphrase somebody else once, and this is not meant to your family, if mom doesn't have it and dad doesn't have it, check the milkman. So who knows? You have to figure out where the genes lie there. But there's 4 of you with HCM in one generation. I'm going to guess mom or dad is the positive, and my money would be on dad at this point. Okay, so now the round robin question, and this one goes out to all of our faculty tonight. The 2020 HCM guidelines were just published 2 weeks ago, and I warned you that this question was coming. What do you guys see in the guidelines that is new, innovative, interesting, controversial, concerning? What are you thinking about the guidelines?
They're a lot better fleshed out. There's a lot more detail about physiology. A lot of the recommendations have been upgraded from maybe a 2B to a 2A, or from a 2A to a class 1.
Let's talk about what those mean first, so people
understand. The strength of the recommendation. So a lot of the typical things we do, like screening for atrial fibrillation, a lot of the atrial fibrillation screening recommendations have been upgraded, which I found encouraging because it sort of reinforces the careful monitoring and care that we already do. And it was nice to see that those recommendations were strengthened. I found it interesting that stress testing with nuclear stress testing is discouraged in these more recent guidelines. And that's also kind of in keeping with what we notice in clinical practice, where we get a lot of false positives from nuclear stress testing. So yeah, I like the new document. I think it's a lot more detailed. And I like to see the strengthening of a lot of the recommendations.
Yeah, anything to add?
Yeah, agree. I think it's one of those things where a lot of the flow charts were things that we did, but now it's kind of clear to many cardiologists out there and primary care doctors that this is kind of the path to follow when it comes to diagnosis or even management and decision making. The one thing that used to drive me crazy was the recommendations for screening of family members who are at risk of HCM was, between the ages of 5 and 18, you screen every 1 year. And then all of a sudden on your 18th birthday, you screen every 5 years. And so magically on your 18th birthday, you went from every year needing to be checked to now you're not going to be checked for 5 years. So it kind of, I used to not do that. I used to kind of do a kind of graded. I used to do every 2 years till you're 26 and every 3 years, and then started doing every 5 years. And that's kind of what the recommendations now do. And Sumathi's chart actually showed that. Now the recommendations are every year until age 5, and then every 1 to 2 years until I think it was age 12, and then every 5 years starting in adulthood, which made much more sense to me rather than having this magic 1 to 5 years on your 18th birthday. It does go through, I just like it makes things much more concrete in one document, which I don't think we've ever had as far as diagnostic management. And it answered a lot of questions about exercise testing as well.
So I go back to having just the consensus paper from like 2003, if my HCM history is in my brain right, and a beg, which was quite a funny event after the valve guidelines got published. I grabbed Rick Nishimura and Bob Bono walking down the hall of ACC, and I linked them by arms. And I'm like, if you can do valve guidelines, you can do HCM guidelines. And they're like, oh God, she's a dog with a bone. And we got the first guidelines out of that. And now it's the second evolution. The good news about the guidelines is we don't have to wait 10 years for them to be revisited. They've changed the process so we can make incremental changes rather than these big changes all at once. So I'm really happy about that. I'm curious to hear about what you all think about the number one item, the first item listed in the new guidelines document, shared decision making. What do you guys think about shared decision making in managing hypertrophic cardiomyopathy? Is it going to make
it is the cornerstone of management, so it was aptly placed there in the guidelines.
I love that it's number one. I love that that dialogue is going to need to be happening. And I think, maybe not with your center specifically, this is a more global thing. I think we're going to have to make sure that our HCM clinics have the time and the resources to make sure patients really understand, and that the work of the HCMA just became a little bit more important so that patients really can dive in and really make good, sound decisions, both on the clinical discussions that you're having in the office and then in the car on the way home, and the other 1,000 things hit their mind. They have a place to come to bounce things off of, and then go back to you to make good decisions, because shared decision making puts a burden on the patient to know what they're talking about too, and work with their team to make the best decision for themselves and their family. What do you guys think about the change in the recommendations on athletic participation? Neither one of them wants to.
I have a fire alarm going off in the background here, so I'll bow out on this one till the alarm is done.
Oh, that was convenient. Kia, you're up. What do you think about that? You're on mute.
I'm muted. So recommendations about athletic participation has been controversial for years to decades. Back in the day, it used to be you have HCM, now you can only play darts. And then patients were getting, that's an exaggeration obviously, but darts and bowling and billiards maybe. And then patients were getting obese, diabetes, coronary disease, depression, other aspects of being sedentary. So the pendulum swung way too conservative for many reasons, to be honest, that I'm not privy to. Maybe Lisa can weigh in on that. And then now we're starting to learn through Live HCM study, as well as other things, that exercise is probably healthier, and we have to find the right kind of the sweet spot. And it still needs to be studied. I mean, it's studied more and more, but I think more and more participation is important. And so I like the idea that this is commented on for officially, rather than us all being scared, nervously telling patients in our clinic, listen, you probably should exercise, but don't tell anyone I told you that, type of thing. So those are my thoughts.
I think it's going to add a lot of complications to teenagers, parents trying to make decisions for teenagers versus adults trying to make decisions for themselves. I think we need to be very aware that there's a difference between a teenager and an adult when making decisions. And I'm a little nervous that some families might feel pressure to let a child do something that they're not comfortable with because it's the child's decision. I think we need to be very careful on the adolescent mind and the adult mind as to where that decision is being made, and that we're being careful, but also letting people live their lives. It's a really tough balance. And I think it's going to end up probably in a courtroom at some point because you're going to have a disagreement on what's reasonable. And I think that we've already had that happen, and schools can get involved in that decision-making process, which adds a lot of complications to things. So while it clarified, the guidelines document clarified a lot of things, I think this one's going to cause some trouble down the road for some families, and they're going to need a lot of support in making some decisions because there's going to be pressures from multiple different stakeholders here, and they may not all be aligned at all times. So I just caution families to really think through not only a particular sport that a child may want to participate in or a young adult, but what other options are available that might be safer in terms of athletic participation. So I'm a little concerned about that. We'll see how it plays out. Maybe I'm going to be wrong. I'd like to be, but I think it's going to cause a little bit of stress for some people, but we'll help them get through that. Anything else from the nurses on the guidelines, from genetics on the guidelines? Any comments? No, you guys are pretty good with this? Okay, so we have one question on mavacamten, and then I am going to, after we answer the question on mavacamten, I'm going to take us down from Facebook Live, and I'm going to turn off the recording feature. And you will have a few moments to ask questions that aren't going to be recorded, that aren't going to live forever on YouTube or Facebook, and that will disappear when this meeting does. So the next question is, will mavacamten, or does mavacamten lower blood pressure? Virginia?
We have not observed that. We kind of wish it did, because a lot of our patients have hypertension that is so difficult to manage with obstruction. But no, we have not noticed that.
Okay. To our Facebook viewers, thank you for viewing. You will be able to see this on YouTube later as well. So thank you for viewing tonight. And we are now leaving Facebook. And you're all going to get a little announcement that we have stopped recording.